It's my pleasure to be part of it, and I'm sorry I couldn't be there in person. I've seen some footage from friends, and it looks like a beautiful meeting. So I'm going to be speaking about patient selection for advanced technology lenses, and I'm from the Wellington Eye Clinic in Dublin. These are my financial disclosures. I think the one that has most uh, application is probably Alcon because I use their lenses, and some of the lenses might be mentioned in the talk. And I always need to declare that I'm on the board of directors of Alcon, and whatever I'm speaking about today is my opinion and not necessarily theirs. So in cataract and refractive surgery, success is equal to outcomes minus expectations. So we need to manage expectations, we need to manage outcomes. The way we manage outcomes is with accurate results, minimal complications, and when we do get complications, managing them well. And expectations we set with consent. Our informed consent needs to be very good. So what does a patient require to have success with these lenses? Well, first of all, they have the ability to neuroadapt to blended vision, or the ability to process diffractive full range of focus lenses. There are anatomical considerations, cornea, vitreous, and macula, and then they need to understand the compromise of there is no free lunch in optics that Gerd Arfaf mentioned. So the solution that's going to work best is the one that achieves the patient's desires within the constraint of the requirements and with the lowest reduction in the quality of vision. So the tools that help are assessing blended vision. Is the person suitable? Using a trial frame in the clinic. We used to use the Viveo visual behavior monitor. It's no longer available, but I'm going to tell you what we learned from that. SYMPOSUM Gecko, and then contact lens trials. All of these help us make good decisions. So I don't need to speak to you about the problem with presbyopia. We know exactly what it is. The key thing is there's no free lunch in optics, as Gerd Arfaf said. And there is no treatment that we can give a patient that will give them the vision that a 20-year-old has, where they can see far and near perfectly. So if you think about what the patients want, they want freedom from glasses and contact lenses. They want to see well, and they want to see well at all distances, and they want perfect vision. You often hear them say they want perfect vision. Well, what can we provide? Well, we can provide very good distance vision, but then the patient will need glasses. Or very good reading vision, then they need distance glasses. Or blended vision, and that entails a compromise, or multifocality, and that entails a compromise. What can we not provide the patient? Well, we can't provide excellent vision at all distances with perfect optical quality. The more complete the range of vision, the greater the visual compromise. And the higher the visual quality, the smaller the range of vision. And we land up in some situation like this where we're always chasing our tails. We just can't get everything we're looking for. So how do we decide between, are we going the blended vision approach or an AT-IOL approach? So the first thing to do is, how suited is the patient to blended vision? Second question is the patient willing to pay more for AT-IOLs? How important is night driving to the patient? And are all working distances equally important? So something that's helped us hugely to help patient understanding is when we start with blended vision, always start with blended vision. I'll say to the patient, if you had 3 eyes, and they look at me, I'll say, yes, then we'd make the one for distance, the one for the computer screen, and the one for reading. And then suddenly a light bulb goes on and the patient says, right, I understand. So they know already what compromise means. Where is it most important to see well? Where are you willing to wear glasses if we don't achieve full success? And where are you not prepared to wear glasses? So blended vision, we look at suitability through a number of tests. I'll go into more detail in a second. And the beauty of blended vision is if there's one part of the visual range that the patient's dissatisfied with, they can wear glasses to correct that, like night driving, for argument's sake. Blended vision, we need to explain to patients what the targets mean. So we normally show them, if we correct both eyes for distance, you need glasses for intermediate and for near. If we make mini blended vision, one for distance, one for intermediate, you need glasses for near. And if we do blended vision, as we typically know it, one for far, one for near, well, then there's a gap in the middle, and you may need glasses on the screen. So they need to understand that compromise. Now, with multifocality, there's also a neuroadaptation to full range of focus, and that includes all the diffractive lenses we know, and then increased range of focus, which are either diffractive or refractive, and give us an increased range, but not necessarily near vision. And with diffractive multifocals, glasses can't really improve night driving. And with increased range of focus lenses, where we've targeted distance in both eyes, which is uncommon, but if we did that, then we need to tell the patient they'll need glasses for reading. So today we have a huge array of designs of IOLs that can help us. So how do we select this? So generally we have three options: an interview and a discussion with the patient, a questionnaire, or objective visual data. Interviews are very useful, but they're subjective, both on our side and on the patient's side. And they can be time consuming. They certainly are an awful lot better than no history. So taking a very good history and trying to identify what the patient needs is important. Questionnaires are very good. And when you look at one like the DEL, for argument's sake, the part that's most important is the last part of the questionnaire that says, are you easygoing or are you perfectionistic? And someone who's leaning towards perfectionistic, we've got to be careful about some of our choices. Right, so the case for objective data, and this is Vivio that we did some years ago, is the patient wore a device like this on their glasses for 36 hours. So we got lots of information on their working distances, ambient light, their head position. And what the device did is it generated a personal defocus curve. And then the defocus curve could be matched with a monofocal, a bifocal, an increased range of focus lens, and a trifocal lens. And based on matching these defocus curves, you could determine which the best lens is for that patient. And we must have used it about 200 times, and we got 200 different defocus curves. The one thing we learned, though, is that we all underestimate how much time we spend at near. So if you get a solution for a patient who's paying more for a lens and they can't read, you either would have had to explain to them very well that this was going to happen, or they're going to be disappointed. Right, so when we speak about 80 IOLs, we've got to take the ocular surface into account. The tear film, we use these tests to make a decision. Meibography, and meibography is important because it makes it very visual for patients what the issue is, and meibomian gland expression. So this is a good tear film. In good meibography, we can use any lens we like in terms of the tear film. An unstable tear film looks like this, and the patient's going to be disappointed with a diffractive multifocal IOL until you've addressed the tear film. And once you've addressed the tear film and things look stable again, you're in a position where the tear film will no longer be a limiting factor. You need to make sure the cornea is fine. So overall, you can see this is a regular corneal shape. On topography, you can see the same thing with a very good profile. What's very helpful is looking at the Fourier analysis. And when you come up with nothing in the Fourier analysis that's a warning signal, then you know from a corneal optics point of view, you're also in a good situation. We often, when we're thinking about blended vision with laser versus diffractive multifocals, would look at the anterior chamber dimensions. This is a person who could have LASIK if they wanted to, but when we look at the anterior chamber dimensions and see how small the volume is, how tight the angle is, and what the AC depth is, then this undoubtedly, this patient's a better candidate for a lens replacement that decongest the anterior chamber rather than laser. A device like the eye trace, and there are many like this, that can give you an idea of the overall optics, and then looking at corneal optics specifically versus internal optics also helps you make a decision which way to go. If you have a lot of aberrations in the cornea, you've got to be very aware of diffractive trifocals in that eye. The ocular scatter index is very helpful. The eye trace looks at wavefront. The scatter index looks at scatter. So we can see what the tears look like. We can see what meibography looks like. And if there's any problems here, it motivates the patient to address their tear film. And we can look at the ocular scatter index. So this ocular scatter index of 1.2 is super important. So you only start becoming cataractus at sort of 2. At 1.2, we'd ask the question of this patient, do you have any glare at night? If the patient says no, we know they'll do very well with the trifocal, because a trifocal full range of focus lens only has an ocular scatter around about 0.9 and a monofocal sort of 0.6. If we found that the patient was very symptomatic with an ocular scatter index of 1.2, you have to think more carefully about, am I going to use a diffractive multifocal? And then vitreous floaters and a PVD are very important for diffractive multifocals. The symptoms are greatly exaggerated in these cases. And then, of course, we need to do OCT to make sure the back of the eye is okay. So blended vision, we test in a way that preserves distance stereo vision. And as I said earlier, any residual deficiency can be corrected with spectacles. This is the technique we use in the clinic. I'm not going to do it in detail, but it's very, very useful to learn. I'm going to show you in a second. There's a QR code that you can photograph, and it will show you exactly how to do this test. What we did about 5 years ago is we stopped using the term monovision and changed it to blended vision. And it was way better for patients. They understood it much, much, much better. And the basic idea is in the phoropter, we correct both eyes to 0, and we then show them at the click of a button with the automatic phoropter what it looks like if the one eye is defocused to -150, and then at the next click if the other eye is. And that way we decide on sensory dominance. And then we also, this is the QR code you can image to see this video. But we also give the patient a distance stereo target, and we see how much we can defocus the reading eye until they lose stereo, and then we go one step back. We always like maintaining distance stereo rather than breaking it down. A trial frame can go a long way in the clinic to give information. This device is a very useful information, the 2-eye SYMPOSIUM gecko, and this you can also use to determine ocular dominance. You can also show blended vision. You can show any trifocal, you can show any increased range of focus lens, you can show combinations of them. So it's very, very helpful. It's a device that is not a simulator. You're actually looking through the IOL optics. So it really gives you a very good idea of what the real world looks like through these devices. And they can be very, very helpful. It's almost like a bridge for the patient from the now to where I might go. Right, so I'm going to show you what the various options. I don't know if you can hear this video. I'm actually going to switch it off. You don't need to hear the video. What we do for every patient is when we see they're in the presbyopic age group is we send out this video before the time. And what this video does, it's a very simple, it's only 2.5 minutes long. And it tells the patient what we've got to think about when we're considering blended vision versus trifocality with the potential glare and halos versus using IROF lenses with some level of blended vision. So they come into the clinic when they come in for their assessment already completely aware of the discussions we're going to be having. And then once the patients come in and they've already decided they're going to be going for a lens implant, we'll explain to them how monofocals work, how an increased range of focus lens works, how a trifocal lens works, what the compromises are, and then how these lenses can be used in different ways to give you different results. So something we do frequently is we do this procedure called custom match. You can do it with any combination of a diffractive trifocal and a refractive increased range of focus lens. So the first thing you do is you implant the trifocal lens into the non-dominant eye. And then 1 week later, you make the decision on what are you going to do for the second eye. In our experience, we're doing this for the last 3 years, 90% come back and say, you know what, this vision is fine. I saw a few faint halos at the start. They're disappearing. I like this lens. I've got a very nice range of vision. I want the same lens in both eyes. So that patient lands up with a trifocal in both eyes. But the 10% to come back and say, yeah, when I do this and I notice those halos, no, I don't want that in both eyes. They then in the second eye get a refractive increased range of focus lens, and both eyes can now see far, both eyes can see intermediate, the trifocal can see up close well, like N5, and the IROF lens can also see some level of reading, and together you get a very good range of vision, but you've protected your ability to drive at night. So this custom match approach has led to a 0 incidence of IOL exchange. As I said, almost 90% off for a full range of focus in the dominant eye, and it epitomizes informed consent. The patients actually had this participatory experience where for a week, they could test this lens out for themselves and make a really good decision. So thank you very much for your attention, and thank you kindly for the invitation. I wish I was there, but this is the second best I could do. Thank you.
Can you just help me too? Thank you.
He can hear.
Okay, thank you, Arthur, very much. We enjoyed in your presentation a lot of modern devices, new technologies. I'm so happy that we have the same protocol for premium lens implantation. I also prefer prefer first in the non-dominant eye trifocal or diffractive lenses, and if patient is happy, then after a few weeks I put in dominant eye refractive or diffractive depending of wishes. So we have two short questions. First one is about stereo acuity. What do you think, how much stereo acuity is important in a selection patients for diffractive intraocular lenses? Is there some cut-off value, maybe, I don't know, 100 seconds or more? So how the stereo acuity in your hands, in your practice, is important for trifocal lenses?
I think it's very important, and I think you increase patient satisfaction if you maintain distant stereo acuity. So the way we do it is we have both eyes corrected in the phoropter to distance. We have a distance stereo acuity chart up, and we then start defocusing the sensory non-dominant eye until the person loses. And we've seen almost everybody can accept 0.75 with no loss of stereo. The massive majority, 85%, can accept 125, no problem. And then maybe up to 60%, 70% can accept up to 175. It's a very personal thing. But I do think that you increase satisfaction significantly when you maintain a level of distant stereo acuity.
Thank you very much. And we have a second question about spherical aberration. We all know that cornea has positive spherical aberration. And what is your, and crystalline lens has negative spherical aberration, and majority of intraocular lenses are high aspherical. So, but after hyperopic ablations, there's change, of course. So what is your target ocular spherical aberration? Is it zero? Is it a little in the plus way? Or do you have any advice about that?
I do. I don't think it'll be new for anyone, but the advice is normally only applicable to previous hyperopic treatments. You've got to avoid a lens with a lot of spherical aberration because you're going to land up with a toxic amount of spherical aberration. So the place to be specifically careful is putting increased range of focus lenses or monofocal pluses into patients with previous hyperopic. If there's a lot of spherical aberration on the cornea, then you may even put a lens in that's neutral, a zero spherical aberration in the lens, in the IOL.
Okay. Arthur, thank you very much for your time. We are honored to have you here with us today, and now we will proceed with the next speaker. Thank you.